Hello and welcome everyone. Today we'll be discussing the management of chest tube. Now Hippocrates in the 5th century introduced the concept of draining the pleural space using a hollow tube, likely for treatment of empyema. In 1889, introduction of valved tubes with airtight seals to prevent the lung collapse from outside atmospheric pressure during inspiration was invented. In 1922, documentation of chest tubes in postoperative care of patients undergoing modern thoracic surgery came into being. In the World War II, chest tubes were widely used to restore the lung function after traumatic thoracotomies. In Korean War, there was a continued use of the chest tubes, which continued to be in the standard of care during the Vietnam War as well. Now, modern evolution, chest tubes and their management has evolved to meet the contemporary needs, including treatment of conditions related to the COVID-19 pandemic, which saw a lot of ICD insertions. So, what are the indications? When there is a potential space between the visceral pleura and the parietal pleura, that is, the pleural cavity is filled with some kind of fluid, we usually introduce the chest drain. It is usually air or any liquid accumulation, which can disrupt the negative intrathoracic pressure, causing a mass effect on the lungs, thereby increasing the overall chest wall workload or decreasing the compliance of the chest wall. The most common is pneumothorax, where the air fills the pleural cavity. It can be primary, spontaneous, secondary spontaneous, or traumatic. Now, chest tube evacuate the air to re-establish a negative intrathoracic pressure, allowing the lung to expand and restore the physiological function. The pneumothorax can be a tension pneumothorax when it is a medical emergency. The next indication is pleural effusion or empyema, where there is accumulation of excessive fluid or pus in the pleural cavity. We introduce these chest tubes. Now, treatment comparisons. A Cochrane review found no difference in the mortality or complications between video-assisted thoracic surgery and chest tube drainage for pleural empyema, but VATS reduced hospital stay. Meta-analysis showed interpleural lytic lesions as a viable alternative to VATS for treating retained hemothorax, which had operative avoidance of as much as 87%. Now, interpleural lytic therapy, tissue plasminogen activator and DNases combination significantly reduced the collection of the pleural fluid and opacity compared to placebo. Now, the tissue plasminogen activator and DNase combination given early phase of empyema treatment is beneficial. Regarding the multidisciplinary protocols involving small bore chest tubes with interpleural plasminogen activators and DNases, if unsuccessful, the next step could be VATS. So next is type of chest tubes. The measurement and sizing. Chest tubes are measured by the internal diameter in French units, where 1 French equals 1/3 of a millimeter in diameter. For example, 24 French equals 8 millimeter caliber of the tube. Now, tubes of 20 French or larger are considered large, and less than 20 are considered small, though some studies use a threshold of 14 French for large bore. Small bore chest tubes, often used as first-line treatment for pneumothorax, transudative pleural effusions, and simple empyemas. A common type is the pigtail catheter, which is a coiled tip to prevent dislodgement. Large bore chest tubes, now required for more viscous conditions like hemothorax, complex exudative effusions, and empyema. Now, efficacy and complications. Studies show a small bore tube have lower complication rates, shorter drainage durations, and shorter hospital stay compared to large bore tubes. Now, small bore tubes are preferred for reducing patient pain due to smaller incision size. The flow efficiency. According to the Poiseuille's law, the flow rate through a tube is inversely proportional to its radius, meaning a small bore tube has lower flow rates. This makes large bore tubes necessary for draining high viscous fluids which could clog in smaller tubes. Regarding the clinical trials have demonstrated benefit of small bore tubes in terms of reduced pain, shorter drainage duration, hospital for conditions like secondary spontaneous pneumothorax, traumatic pneumothorax compared to large bore tubes. Now next is insertion. Once you have decided where you want to put the chest tube, the next you have to look for the ideal insertion point. The triangle of safety is considered by the latissimus dorsi, pectoralis major, and the base of axilla, and above the fifth intercostal space. So above the fifth intercostal space, the base of axilla, the edge of the pectoralis major muscle, and the edge of the latissimus dorsi muscle, this area is called the triangle of safety. For apical pneumothorax, consider the second intercostal space in the mid-clavicular line or lateral insertion in the fifth intercostal space. Nowadays, the fifth intercostal space is more preferred. Regarding positioning the tube anterior to the anterior superior iliac spine, this is done to prevent the occlusion when the patient is supine. Lower intercostal spaces for pleural effusion, avoiding the diaphragm and internal organs, can be done if the collection is located in a more lower down area. So this is the diagram you must remember. The angle of the bed must be 30 to 60 degrees, and this is the triangle of safety, and most likely you should go in the fifth intercostal space for most of the chest tube insertions. Now the point you needs to know is the chest tube must be inserted just above the rib so that you avoid the neurovascular bundle. Since the bundle goes in the lower edge, you must go in the top upper margin. Now create a small incision and blunt dissection through the pleural cavity, ensuring the direction is posterior and apical. Once you have dissected this place, then you must dissect in a posterior and apical direction. This is the direction that you must go, posteriorly and apically. Use ultrasound guidance, guide wires and dilators for more precise insertion. Now, for trocar is less preferred due to higher complication rates because of a rigid tip. Seldinger technique is more preferred. Now, ultrasound can be used, essential for identifying internal landmarks and ensuring accurate placement because you can see the fluid. Secure the tube, secure it with a suture to prevent dislodgement. Few individuals with low body mass index use an untied suture at insertion for easy skin closure upon tube removal. Now, preventing complications, use a finder needle to avoid intercostal neurovascular bundle. Ensure the tube placement avoids direct insertion into the oblique fissure to prevent entrapment post expansion. Be mindful of adhesions. Do not bluntly dissect to avoid vessel disruption and potential hemothorax. Now, regarding the tube placement, advance on the superior edge of the rib to dodge the neurovascular bundle. Orient the tube posteriorly and apically within the pleural space as I have shown. Confirm the most proximal hole is inside the pleural cavity for functionality. These are all things which must be clearly kept in mind when you are inserting a chest drain. The last point is very, very crucial to ensure that the proximal hole is inside the pleural cavity and not just inside the skin. Now, next is how to manage a chest tube. Now, there have been a evolution of the drainage system over the years. In 1875, Fairplay introduced a one compartment system with a one-way valve for air egress. In 1926, Lienthal developed a two compartment syndrome allowing fluid collection without drainage efficiency compromise. In 1952, Howe introduced a three compartment system combining collection, water sealing and suction, and a manometer capable into a single pleural drainage unit. The modern pleural drainage units are digitally operated, incorporate the foundation elements of the previous systems, and regarding the setting and usage, chest tube can be connected to these pleural drainage units and set to either active suction or water seal, the latter being a form of dependent drainage. Now, the term water seal refers to disconnecting the tube from active suction, with modern PDUs featuring a built-in water seal chamber to prevent the air return. Clinical trial and evidence. Studies have explored the efficacy of water sealing versus active suction in post-operative care. Early water sealing post-thoracic surgery showed benefit in reducing air leakage but had limited benefits for large leaks. A larger trial by Brunet et al. Did not find advantage of water seal over suction, suggesting that a hybrid approach to moderate suction and water seal for patient mobilization. Now, regarding the special consideration that you must keep for traumatic chest injuries, evidence favor low pressure suction over water seal, particularly in patients under mechanical ventilation to prevent a tension pneumothorax developing. General management principle: the choice between suction and water seal depends on the specific indication of the chest tube and general preference for suction to expedite air leak resolution in post-surgical and traumatic injury context. Now, how to remove? Note the fluid quality. Before removal, the fluid should not contain chyle, that is the milky body fluid mixing the lymph and emulsified fat indicating a lymph leakage, blood suggesting an ongoing bleed, or purulence. If any of this is present, then you should not. The acceptable amount of fluid output removal widely, with recommendation ranging from 200 to 500 per day. This lack of consensus highlights the need for individualized decision making based on patient's recovery and specific circumstances on which you have inserted those chest tubes. Regarding the studies and recommendation, the Serfolio et al. Suggested that removing a chest tube up to 450 ml of fluid per day is acceptable in elective pulmonary resection cases. This higher threshold potentially allows patients to go home sooner with minimal increase in readmission rate due to recurrent effusion. Now, but Grozzi et al. Found a higher readmission rate of pleural when applying the 450 per day threshold, prompting a return to a more conservative 200 ml per day threshold. Now, challenges in determining the optimal removal time. Studies present limitations such as unreliable follow-up, small sample size, underlying the need for larger, more definitive trial to better understand the optimal threshold for chest tube removal. Now, the removal technique. There is a debate on whether to remove the chest tube at the end of expiration or inspiration. Removing at the end of expiration, particularly using a Valsalva maneuver, minimizes the pressure difference between the atmosphere and the pleural space, potentially reducing the risk of a complication. The overall idea is there should not be a negative pressure in the pleural cavity when you have removed the tube. But if the patient is on ventilator, there is always a positive pressure in the pleural cavity. So you can remove it at any point of respiration if you want. Other recommendation focus on the use of Valsalva maneuvers during removal without specifying the respiratory phase to ensure that the pleural cavity is closed as much as possible upon removal. Now, the closure of the chest wall cavity defect. Immediately after removal, the site should be properly secured either with a pre-placed suture or an occlusive dressing to prevent air entry and to ensure proper healing. The complications that we can face. The risk factors being the placement in the emergency department by emergency medicine clinician or in patient with a BMI of greater than 30 increases the risk of complication. Complication rates are variable. Reported complication rate for chest tube can be as high as 40% with variable attribute to difference in categorizing complications. Standardized complication reporting. Aho et al. Proposed a standardized method of dividing complications into 5 categories to facilitate a consistent reporting and data collection. That is insertional, positional, removal, infectious, and malfunction. These 5 being the criteria under which the complications need to be reported. Now, complication categories: insertional being injury to the intrathoracic or extrathoracic organ within 24 hours of insertion, often associated with the trocar insertion technique. The positional is complication occurring after 24 hours of insertion, including organ erosion, tube kinking, obstruction, entrapment after expansion. Removal: issues such as failure to seal, leading to atmospheric air entry or retention of foreign body post removal. Infectious arising from external or internal sources. Malfunction: problems related to the chest tube or equipment functioning. Now, implications for clinical practice. By defining these categories, clinicians have a foundation for comparing the data across studies and developing protocols aimed at reducing complications associated with chest tube placement and management. Regarding COVID-19 and the use of ICDs, the use of PPE, emphasizing the use of appropriate PPE by healthcare workers handling chest tube to protect against virus transmission. Now, adjustment the chest tube management protocol to reduce reliance on water seals that might increase aerosolization risk, and implementing filters within the chest tube drainage to capture and reduce the number of potential infectious aerosol released into the environment. A specific study compared the efficacy of connecting two closed underwater systems in series with the air filter on the second system, demonstrating a decrease in the dissemination of the coronavirus. This setup reportedly protected healthcare workers in a study in COVID-19 infection. Though the study acknowledged limitation of having small size. Regarding the future direction, ambulatory devices for spontaneous pneumothorax. A study by Halifax et al. Highlighted the using ambulatory device for managing primary spontaneous pneumothorax resulted in significantly shorter hospital stays and compared to traditional methods like aspiration or chest tube insertion. Despite this benefit, the increase in adverse effects such as enlarging pneumothorax, issues with device itself, suggested a need for further research before it can become a standard of care. Conservative treatment of pneumothorax. Brown et al. Found that observing large to moderate size primary spontaneous pneumothorax are not inferior to place a small port tube for resolving pneumothorax within 8 weeks. This challenges the conventional necessity for decompression of chest tube in all hemodynamically and respiratory stable pneumothorax, suggesting a more towards less invasive management. Now, post-thoracic surgery. Zhang et al. Compared the use of novel air extraction double lumen catheters with traditional chest tube post-thoracic surgery, finding no inferiority in preventing pneumothorax on the first post-operative day, notably, and the lower pain scores. This supports the potential of less invasive techniques to improve patient comfort without compromising on the clinical outcomes. Now, to summarize, this is how the flowchart should be there for managing a chest tube in the hospital or ICU. Assess and indication. Determine the need of clinical assessment and imaging before you find a need to put a chest tube. So you can go for chest x-ray, CT scan or ultrasound to determine why am I putting the chest tube. Now, once you have decided that you are going to prepare your equipments, select your tube, use appropriate PPE, ensure the field is sterile and obtain a consent for the procedure. For insertion, identify the triangle of safety and adjust based on the conditions or specific indications in that patient. Regarding the insertion technique, choose your method. Preferably use an ultrasound because it will help you guide. Make an incision, advance the tube, avoiding the neurovascular bundle. Go in a posterior apical direction always. Chest tube connection. Connective to a pleural drainage unit. Choose water seal or suction based on need. A water seal can be used in all cases. Regarding the ongoing management, monitor the drainage that is happening every day, the patient's clinical status and the suctioning requirement. Now, criteria for removal, look at the quality of the fluid, the quantity of the fluid, resolution of the overall clinical condition of the patient. And once the removal procedure is being done, plan removal with a Valsalva at expiration and close the chest wall defect very securely. Post-removal care, monitor for the complications, schedule a follow-up imaging. Regarding documentation, document the procedure well, write your indications, the technique done, the chest tube used and the complications that were noted. Thank you for your patience.